So good morning, Minneapolis, from the afternoon in Edinburgh in Scotland. I'm Catherine Calderwood. I'm the Chief Medical Officer for Scotland, and I'm also a practicing OBGYN with a passion about reducing stillbirth and improving the care for bereaved parents. When I say I'm the Chief Medical Officer, I always need to explain to international audiences, because you will have chief medical officers in your hospitals, in your districts, but I am the chief medical officer for the whole country of Scotland, not just a little bit of it. And I hope that you can hear me. I apologize if I glance down at some my notes so I know which slide I'm on, but I suppose I'm really going to tell you about the journey that brought me to the story I'm going to tell you of Scotland's reduction in stillbirths. It's my favourite story. I give up to 70 talks a year, and this one is my absolute favourite. So it started when I was 34 weeks pregnant with my first child. She is about to leave school. She's nearly 18, and I was on call as the OBGYN resident, and it was the full weekend you did then, with Friday, Saturday and Sunday, and home on Monday morning. And there were 3 women that I remember from that weekend. So picture the younger me, 20 years younger me, with my 34-week pregnancy, and the first call came on the Friday evening. There was a woman who'd come in, the baby was breech, and they couldn't find a heartbeat. So of course the resident is called and the woman is scanned, and some of you may maybe have experienced this either on the healthcare side or the parent side. There is nothing worse than saying you can't find a heartbeat, and neither can I. So she was Friday night, she was about 34 weeks pregnant, and you feel as the obstetrician the guilt of having a baby that has a heartbeat. So we got through that one. She went home. You know the story of what we do. So the next day, a 15-year-old. She was about 5'11", tall girl. I still remember what she was wearing, and she was with her mum. And she was term plus 11, and she was coming to decide when we were going to induce her. And there was no heartbeat. And that baby had when eventually that baby was delivered, there was a true knot in the cord, and she was 15. And the third one, the same weekend, was Sunday night. There were twins in theatre. I don't know whether it's the same where you are, but the consultant was at home, and the OBGYN resident, that is still me, was in theatre with the twins. And I was called out of theatre because a woman in the later stages of labour who was pushing had a massive drop in the fetal heart rate. But I wasn't 2 people. So I was trying to do the twins and trying to get them to phone my senior. And so that baby was born still, 3. And of course I saw those mothers every day afterwards when they were still in the hospital, and I was still pregnant with a baby that was alive. And that's where the story, I suppose, starts. Because many, many years later, I came to be the chief medical officer in Scotland. And they said to me, we would like you to help us reduce the stillbirth rate in Scotland. Well, you don't need to guess what my response was. So at that time, we had 1 in 17 babies die in either as a stillbirth or a neonatal death across the UK. So what? Sorry, 17 babies a day. 17 babies a day was a rate of about 1 in 150 pregnancies that ended in a stillbirth. And what we had was a campaigning group of parents who came, maybe like you are, maybe like your star legacy is, who came to say, we don't accept that there's nothing we can do. And they came to me as the newly appointed doctor in the Scottish government. I wasn't the chief medical officer then. I was just appointed to deal with women and children's health problems. And they said, will you help us? We're going to show you some statistics that will make you want to help us. And you can tell that already I didn't need persuaded to want to help. So I can move to my first slide with stillbirths in high income countries. So they showed me that in the UK, we had the highest stillbirth rate at that time of all high income countries in the world. Though that is not a comfortable position to be in, I think. You are the pink, that it's not very easy to see. The USA's the pink line. You are well below us then. So we move to the next slide, where we can see then that, again, we have UK and Scotland up high with fetal and neonatal mortality. And down at the bottom, we have countries in Scandinavia who were doing very much better. So I looked in particular then at one country, and we'll have the next slide. So this is the Scottish Perinatal and Infant Mortality and Morbidity Report in 2010. The arrow is because we changed the definition of stillbirth from 28 weeks to 24. And what you see is that those lines, the stillbirths are the blue line at the top, and then neonatal deaths in the green line, and post-neonatal deaths purple. But if you see that those numbers have not really changed for 30 years, so people said you can't do anything about it. We need to just say to women and families that this is the stillbirth rate, and it's the stillbirth rate. That's the way it is, and they need to think that 1 in 150 babies will be stillborn. That's not changed for 30 years, and that's just the way it is. So if we look at the next slide, which is of Norway's stillbirth rate, that turns out actually not to be true, that it has to stay the same. Because what I saw when I looked at the data was that Norway had managed to reduce their stillbirth rate by 30% over the same time period that ours had not really budged at all. So why were we accepting? Why were parents coming to me to say, we don't want you to accept that this is just the way it is. We want you to help do something different. There are other countries where there's something different to be done. So I started to look at our data generally, and on the next slide, you'll see that what we were doing in Scotland was lots of good things with data. So this is 2011. We had about 200 people killed in road traffic accidents in Scotland per year at that time. 3 of those were children. We had about 40 cot deaths a year. And then in pregnancy, women were dying. About 10 women in Scotland a year. Our population is about 5.4 million people. And then there was something that we spent a lot of time doing, which was looking for people who had clots in their lungs and clots in their legs, so we could prevent them from dying. And there were about 18 of them. But if you see the number of stillbirths, then that was really quite a big number compared to those other numbers that we were doing lots of things about. So I decided that I would look and see what we were doing with the people killed on the roads. So the next slide will show you that way back in the 1950s, nobody really had cars. So there weren't very many people killed on the roads because there were far fewer cars. So when the people with the cars got the cars, what happened was they got more and more cars, and then they killed more and more people, as people didn't know about road safety, did they then? And then something happened that we thought, gosh, this isn't really great, is it? That there are 900 people killed every year in road accidents. I think we probably need, as a government, to think that this isn't a good thing. So we started to change that then. And so if we look at the next slide, what we did was we thought, I don't know, let's do some clever things about reducing the road deaths, because those numbers are awful. We can't have 900 people killed a year. That's awful. So what did we do? So I thought, what did we do with road deaths? Well, we took targets and ambitions. We if you remember that last slide, this was a very rapid decline in road deaths. 900, nearly 1,000 people declined over a very short period of time to less than 200 a year. So we set some targets to say we were going to half the number of road deaths. We're going to halve the number of road deaths over a 10-year period. We're going to find out why people die on the roads. We're going to talk to the people that work with the different agencies that could be responsible for improving safety on the roads. And we're also not going to accept it. We're not going to say that it's okay that people die on the roads. We're going to say that it's not okay, actually. And we need to say that the responsibility is that we change this. And we're going to try and reduce risk. And we're going to find out why these deaths occurred. And we're going to look at people driving for life so that they, even before you're a driver, maybe we could look at what the risks might be for that driving history and make sure that you are doing the most that you can to prevent you having an accident. And the important thing as well is that we thought that people are not perfect. And so we need to make sure that we have a system which keeps the people safe on the roads regardless of human error. And it worked, didn't it? The road deaths reduced. They were reduced by 75–80% in the time that the stillbirth rate had stayed the same. And I thought, maybe we should do the same. Let's do the same. So if we look at the next slide, we were talking about reducing stillbirths and neonatal deaths by 15%. Well, I tell you what reaction I got from the obstetric and neonatal community. You can't see me folding my arms. They folded their arms and they said, "Don't, Catherine, don't be ridiculous. The stillbirth rate hasn't changed for 30 years. What do you mean you're going to reduce it in 5 years by 15%? Where did you get 50? Where's the trial? Where's the study? Where's the place that tells you that you can reduce it by 15%? What do you mean you are going to make us fail?" And you'll see that we called them avoidable deaths. Of course, we didn't want to be challenged with the unavoidable ones, which they said would be impossible. There is not, Catherine, you're mad, you're setting us up to fail. And I folded my arms back at them and I said, do you know what? I don't know why it's 15%. I'm going to tell you it's not 50% because you wouldn't even have started trying. And I'm also going to tell you it's not 5% because that's too feeble. So we're going to do 15%. And we're going to do 15% because that sounds good to achieve. and there's no evidence that we can achieve it, but we're going to start somewhere and we're going to try. So as I said before, I think the next slide is back to the, is that back to the road? No, is this preventing stillbirth difficult?
Mm-hmm.
Yeah. Yes. So I said, why would we think that we couldn't do it? So if we think, do we take people at risk? Back to the road deaths. Do we talk to people about risks? Do we talk to them about some of the things that could change or could be something they could look out for? Do we talk about prevention? Do we put bumps in the road and safety cameras to watch people? Do we talk about things that are really good advice about the baby's movements not being as much as they were before, and maybe you should seek help? Do we look for the small babies, the ones that are struggling, the ones that are screaming at us and waving and saying, please, I'm in here. Please notice that I'm not doing as well as I might be, and please do something about it. And do we then look at those babies and monitor them? So is it difficult, I wonder? So we know the reasons that babies are stillborn, and we could do something about that. The next slide back exactly to the ambition of the road jets. We took various aspects of what killed people on the roads, and we set targets and ambitions, and we looked at why people died, and we talked to them about why they died, and we put in safety measures like bumps in the road and speed cameras and warning signs and traffic cops, and we did a whole lot of things with people who weren't even drivers. Like we taught the children about road safety. We looked at things that were going to prepare people for not dying on the road. So maybe that would work. And so I think the next slide is probably my most favorite slide ever, because I was wrong about the 15%. I was really wrong about it. They said I would be wrong. They said, Catherine, you'll not do it. You won't do it. You won't achieve 15%. And that's because I didn't achieve. We didn't achieve 15%. What did we achieve? 23% reduction in stillbirth. So I had to admit to my colleagues that I was wrong. Really wrong. They were really, you know, they were right. 15% were a ridiculous number. We should have aimed for better, actually, not less than. Where did you get that number, Catherine? Where was your 15% from? There it is. So I think the next slide shows the averaging rates of stillbirth. Yes. So we've done a consistent launch since the launch of our patient safety program for maternity, which I'll tell you a little bit more detail about. We have then had a sustained reduction, which has then over years been 23%. And the next slide shows you that our 15% for the neonatal mortality was also wrong, because we achieved 16% in the time. So don't let them tell you it can't be done, because it can be done. And you will find that what we've done, I think the next slide then shows you the different ways that we have approached it. So we have fetal growth, fetal movement, and fetal monitoring. And our program is Maternity Care Quality Improvement Collaborative, or as we would in Scotland, MICQUIC for short. And so we have a website. You're very welcome. Just look at that. You can sign up to join that, and you'll get more information than as a member of that. What we've really done is taken those three key areas, so fetal growth, fetal movement, fetal monitoring. So the fetal movement, we have a standardized leaflet which is given to all women across Scotland, advising them about fetal movements, advising them that it's not true that your fetal movements reduce after 36 weeks because the baby doesn't have enough room. What? Really? As we used to advise them that. And we've got people then to come. Our colleagues in the hospitals said, but if you tell them to come when their babies aren't moving, we will be flooded. The doors will be open. They will flood in. They will come, and then there'll be nothing wrong with them at all. And so we had a 6% increase in people presenting with reduced fetal movements. 6% in a busy obstetric unit is not inconsequential, but it's not the drama that they thought they would have 50% or 100% more people. And I'd have thought a few extra people presenting with reduced fetal movements, many of whom, of course, were appropriately presenting with reduced fetal movements because they had a problem. Their baby was waving and saying, I'm not feeling so good, I've stopped moving, can you notice me, please? So we introduced a standardized protocol for dealing with reduced women presenting with reduced fetal movement. Rather than just being reassured and patted on the back and sent away, we properly monitor, and we bring people back if they have more than 2 episodes of reduced fetal movements. And it's not the time now, but we can share all of the detail of those protocols with you if you're interested. We really looked at our small babies. And my own unit, I said, I'm still practicing as an OBGYN in my clinic, when I can get to it, my own unit neonatologists say, Catherine, we've got these tiny growth restricted babies in the cots now, in the level 1. So they're just really keeping warm and being fed till they can go home. Why are there these more little babies? And I said, well, that's because they're alive. So they're coming to be admitted to your neonatal unit. We didn't find them before, so you never saw them. And so they, anecdotally, it is, of course, but they notice an increase in the number of growth-restricted babies that they're having to do very minimal neonatal care for, but the babies are going home with their mums and dads, and they weren't before. So the fetal growth is a big difference for us. I'm monitoring women at risk, as I went back to the road deaths scenario. If you're a risky mom, then you need to be monitored for the things that we know and have known forever were risks for stillbirth. And then we have fetal monitoring. We've done a lot around our fetal monitoring in labour. We have a whole set of, again, standardised protocols for escalation, standardised protocols for women who should have continuous monitoring, and also standardised protocol for where we would start to intervene. So different levels of risk mean different levels of intervention. And we have a fresh eyes approach where when you get to a certain level, you call somebody else, because as we all know, fetal monitoring is not accurate. It has its own downsides, but you bring somebody else in to help you with that. So those are our mainstays, and we have then changed our, I hope we're on the next slide, or maybe it's the same slide, that says that our ambition, of course, isn't 15% anymore. It's 35%. Because we've got to keep going with these targets, with the aims. Why we got to 22.5%. Why would we not keep pushing? So we will go with this more. We will also have, I think, this maternity care improvement collaborative is now established. This is business as usual in Scotland now. No longer are we accepting that the rate of stillbirths is 1 in 150 pregnancies. We don't accept it. We don't take that as being something that can't be changed, because as I've just shown you in my story, it can be changed, and it can be changed very successfully. And I think my next slide is our Scotland's baby box. So yes, no, yes. We have we've introduced this as a government. We offer this to all pregnant women. They get a big box of clothes and bath temperature monitors and baby books and floor mats and kick mats and a little sling to wrap yourself around your baby. And we have really decided that is a universal gift from the Scottish Government. It's a universal gift from us to all our pregnant women and to the 165 women a year whose babies might have been stillborn in the past but are not anymore. So we have more babies to give our boxes to, and we're really thrilled that decision, I suppose, to take what was a problem that was maybe not something that was important. My mum's best friend, who is now 80, sat beside me at a lunch when I was telling her some of what we were doing in Scotland, and she said, "You probably don't know, Catherine, but my first baby was stillborn. My husband phoned the hospital to see if I was ready to come home, because of course in those days, many years ago, 50 plus years ago, the husbands weren't there. So he phoned to say, I'm just wondering how my wife is doing. Has she had the baby? And they said to him, you can come and collect your wife now, but there won't be a baby coming home with her. And that was it. She went home without her baby, and she was told that probably she would feel better if she had another baby. Well, don't we know that that's not the case? So that's a 50 or 60-year-old attitude that probably pervades the reason why I was able to show you that very first slide, which showed that the stillbirth rate in the country that I was living and working in hadn't changed for 30 years. And yet, if you tackle the problem, the stillbirth rate is not the stillbirth rate. If you focus on what you can do to prevent it, the stillbirth rate, I hope I would come back to you in another few years' time and tell you that it's 35% lower than it was. But it's at least already 23% lower than it was. So I finished because I know the time is precious, and maybe you want to ask some questions. Maybe I get the person with the slides. I was going to talk some other stuff, but if you flick right to the end, because it has my contact details, I think right at the end, and my Twitter account, and we can maybe speak and communicate. And what I would love is that if you can hear what I'm saying, don't listen to them when they say that it can't be done. Don't be my colleagues who folded their arms and said, Catherine, it's 15%. Don't be ridiculous. And if I can do it, you can do it in Minneapolis too. Thank you very much.